Hello, I cannot hear.
So am I audible sir now?
Yes, you are
Okay.
audible
So good afternoon,
now.
respected faculties. So today I'll be presenting the topic on the Begg's philosophy and technique. Um, so going to the contents, we'll be talking about the evolution of the Begg's appliance, Begg's philosophy, Begg's technique, components of Begg technique. Then we'll discuss about the different stages of the Begg's technique, and finally we'll discuss about the modification of the Begg's appliance. So going to the history, Percival Raymond Begg, he was born in 1898 in a small town of gold mining, Australia, West Australia. And after graduating from the Melbourne University in 1923, uh, Dr. Begg went to California in 1924 to study under Dr. Engel. And while he went to study under Dr. Engel, at the same time, Dr. Engel uh, was developing the age-wise arch mechanism. And since at that time Dr. Engel was very ill, it was Dr. Begg and along with him, the Fred Sai of Japan, who first treated the patients with the age-wise appliance. And at that time, the Begg was also was became familiar with the uh, ribbon archway mechanism during the study. So in November 1925, Dr. Begg sailed back to Australia, where he began practicing orthodontics in Adelaide, South Australia. And after practicing for 2 years on the basis of the Engel's concept of non-extraction, uh, through the age-wise treatment, Dr. Begg, he was very unhappy about the post-treatment profiles, and because of the severe treatment relapse he got. So in February 1928, Dr. Begg began to routinely remove the tooth and reduce the tooth width by mesodistal striping. And after he changed the mechanism into the extraction therapy, he began to realize that the age-was mechanism was not designed to rapidly close the extraction space and to reduce the deep overbites. So to facilitate such changes, he began using 0.020 round platinized gold rather than the rectangular archway which was used in the big age-wise slot in 1929. And in 1931, he began utilizing the 0.018 inch round stainless steel wire. So during the study under Dr. Engel, he got the exposure of the ribbon as bracket, and the ribbon as bracket of the angle was it had the slot which was opening incisally, and it was also got the exposure of the edge-wise bracket, which he first treated the patients with the edge-wise bracket. So while changing the mechanism into the extraction therapy by Begg, Dr. Begg found that the age-wise mechanism was not suitable for the extraction mechanism in order to close the space quickly. Because in the age-wise mechanism, it had the two-point contact, and it produced the it applied the force to the root and prevented the rapid closure of the space. So Begg modified the ribbon as bracket, which he got the exposure during the study under Dr. Engel, and he changed the slot of the ribbon as bracket into the slot which was facing gingivally. Initially, the ribbon as bracket had the slot which was facing incisally, but the given the Begg modified the Gibbon bracket, and he changed the vertical slot into facing gingivaly, so that the placement of the bracket was became easier for him. So in 1933, after 3 years, after switching from the rectangular to the round archway material, Dr. Begg started using the ribbon arch brackets. And in the early 1940s, Dr. Begg met Arthur J. Wilcock, who was the director of the metallurgical research projects, and he asked him to fabricate to the archway so that he could which could make his demands. So Wilcock produced the Australian archway that combined the balance between the hardness and the resilience with a unique property of zero stress relaxation. And then Dr. Begg started using the Australian archway in his Begg mechanics. So in 1954, Dr. Begg published the article that was entitled Stone Age Man's Dentition, and because of this article, several of his contemporary orthodontics, example Dr. Spencer Atkinson, Dr. Robert Strang, and Dr. Charles Witt, got attention after the publication of his article. And in 1956, Dr. Begg published another article which was entitled Differential Force in the Orthodontic Treatment. And because of this article, many orthodontists from around the globe visited him. And in 1957, Dr. S.D. Kessling and Dr. George DeSam came from the United States to meet him. And actually, Dr. S.D. Kessling was the first person in the United States to practice Begg mechanics. So, after gaining so much of popularity, Dr. Begg he began to work more on his Begg mechanics, and he divided the Begg mechanics into 3 stages. The first stage was stage 1, in which the rotations and the anterior deep bite was corrected. This is stage 1, and in case of stage 2, the closure of the stage is achieved, and in case of stage 3, the uprighting of the root is done in order to achieve the paralleling of the each tooth. So the advantages of the Begg's appliance is that it allows many corrective tooth movements that occur simultaneously, the minimal patient discomfort, and the minimal trauma to the hard and soft tissue, because it applies the right continuous process, and it also allows the rapid aesthetic improvement by the early reduction of the overjet and overbite. It also allows the early correction of the rotation, and also it allows it has this short treatment time because of the rapid movement of the tooth. So let's go to the Begg's philosophy. Basically, he has given 3 philosophy during his time. The first is the theory of the attritional occlusion, which he gave after the study in the Australian Aborigine. The theory of the differential forces. This was based on the work of the Story and Smith. And the theory of the right wire technique, where he uses the right forces in order to move the tooth. So going to the theory of the attritional occlusion, in 1939, Dr. Begg 1939, Dr. Begg wrote his doctoral thesis, that is the evolutionary reduction and degeneration of the man's jaws and teeth. And in 1954, Dr. Begg published the paper entitled Stone Age Man's Dentition after his observation in the Australian Aborigine. And Dr. Begg coined the 2 terms, that is the textbook normal occlusion, which he observed in the civilized man. And in the civilized man, he observed that there was no attrition present in the tooth. And this was basically, the non-attrition was basically present because of the soft diet of the civilized man. And he coined another term, that is the correct occlusion. And he said that the correct occlusion is not a fixed anatomic state, but a changing functional process undergoing the continual modification and adjustment. and he observed the observation before the writing the article. He made the several observations on the Australian Aborigine, where he found that the severe attrition that was present in the uh, on the Aborigine Australian Aborigine person, and the attrition was present in such a way that it was the dentition tried to achieve age to age duration. So he observed that the attrition was present in such a way that the initially the attrition was oblique in direction, and finally the attrition was achieved in such a way that it is flat and edge to edge bite is achieved. So he also observed the attritional occlusion in the deciduous dentition, and he found that all the deciduous tooth is undergone attrition, and this attrition allows the movement of the permanent tooth majorly. And this attritional occlusion also allows for the eruption of the permanent tooth into the correct occlusion. For example, in this Australian Aborigine person, the attrition of this primary tooth allows the major movement of the major movement of the molars and achieve the correct molar relationship. Whereas in the civilized man, the attritional occlusion is not present, and the erupting molars achieves the abnormal molar relationship. For example, in this case, there is not enough of the attritional attrition, and the major movement of the molars is prevented, thus resulting in the abnormal molar relationship. And also the erupting premolars. So this upper one is in case of the civilized man, where there is lack of the attritional occlusion, and the erupting premolars, this does not is not is not because of the lack of the attritional occlusion. The erupting premolar is not majorly moved. Whereas in case of the figure B, that is in case of the attritional occlusion, the erupting premolars are majorly directed, and this can be proved by. So this is the mental foramen. So in case of the civilized man, the erupting premolars are not majorly inclined, whereas in case of the civilized man, this is the mental foramen. So we can say that in case of the civilized man, the erupting premolars are majorly drifted. And also in case of the Australian Aborigine person, the attrition also allows the space for the eruption of the third molars. When the attrition takes place, and drifts majorly, it allows for the room for the eruption of the third molars. So this is the superimposition of the attrition over the non-attritional occlusion to illustrate the amount of space that was created for the eruption of the third molars. So the average reduction of the length from second molar to second molar in case of the mandible was found as 10.56 mm, and this reduction was 1 mm less in case of the maxillary arch. And also in case of the civilized man, the contact point is less in case of the non-attritional occlusion, whereas the contact point is broad in case of the Australian Aborigine, and this also prevents the periodontal disease in case of the Australian Aborigine person, because the length from the contact point to the gingival margin is increased, and this might result in the periodontal disease. Whereas in case of the Australian Aborigine person, the distance from the occlusal portion to the gingival portion is reduced, and this also helps in the reduction of the periodontal disease. So this study in the Australian Aborigine person helped him to guide in the treatment mechanics of the Begg's technique. So attritional occlusion. So observing the attritional occlusion in the Australian Aborigine person, started doing the tooth extraction, and that was basically the first premolar. and he also did the proximal stripping in order to counteract the non-attritional occlusion in the civilized man, civilized, civilized people in the. So let's go to the another Begg's philosophy, that is the differential force. And in 1900, the differential force philosophy, this was basically explained in his article in 1956, and it was based on the work of the Story and Smith. And this differential force is defined as the force that results in a differential rate of the tooth movement at one end than the other. So when, according to Story and Smith, when 150 grams of rest force is applied, there is no movement of the either the anterior or the posterior teeth. And when the force is between 150 to 200 grams, the anterior tooth, the tipping of the anterior tooth takes place. And when the force is between 300 to 500 grams, the posterior tooth starts to move, and not the and the anterior tooth remains stable. So using this work of Story and Smith, the Begg gave the concept of the differential force. Now, another philosophy that that Dr. Begg gave is the right wire technique. So, in the right wire technique, the Begg devised the bracket, that is the Begg bracket, which is also called as the modified ribbon bracket. He used the round arch wire, and this round arch wire produced the right forces, and because of this right forces, this does not produce the undue strain in the investing tissues of the tooth. Now let's go to the components of the Begg appliance. So it had the principal component of the Begg appliance is the archware material, and it is the Australian archware. And the archware mainly used is the 0.016 inch diameter archware, and also 0.020 inch archware that was mainly used in stage 2 of the Begg's treatment. And this Australian archware produced the force for longer duration without the frequent reactivation over the long distance. And but the disadvantage of this Australian archware is that it fractures easily. So while doing the wire bending, we should be very cautious because it might result in the fracture of the archware. So in case of archware bending, we should not do the Australian archware bending in the round diameter of the archware, because it will produce the undue it will produce the stress and might result in the fracture of the archware. So we should always do in case of the rectangular and the rectangular part of the board weak prior while bending the Australian archware. So the another component of the Begg's technique is the modified ribbon arch bracket, that is the Begg bracket. And it has the slot of the 0.020, and so this is the slot of the Begg bracket, and it has the and it has the pinhole, and this is the pinhole. So with the application of the pin in this slot, the archware that can be fit in the this vertical slot is either 0.016, which is generally used in case of stage 1, and the pin can be inserted so that only 0.020 archware is left, which is generally used in case of the stage 2. So the bracket is generally placed at the distance of 4 mm in the incisor bracket, and it is in the incisor bracket, and it is major distally placed at the center. And in case of the maxillolateral incisor, it is placed at the distance of 3.5 mm. Whereas in case of the lower teeth, the central and lateral incisor has the distance of about 3.5 mm to 3.5 mm, and in case of cuspid and bicuspid, it has the distance of 4 mm in both the tooth. Now let's go to the band material. So the band material is made up of the stainless steel stripes of the different size and thickness, and these are recommended for the different teeth, and these are available in the 8 feet rows, or it can be cut into the 2 inches to 2.5 inches. And the different dimension of the band material is used. For the canine, it is 0.02125 to 0.003 inch. For the canine and premolar, it is 0.15 to 0.004 inch, and for the molars, it is 0.15 by 0.005 or 0.18 by 0.006 inch. So the at the different stage of the Begg technique, the lock pins are used, and in case of stage one, the 1 point safety lock pin is used, and this 1 point safety lock pin reduces the vertical slot into the 0.016 inch, so that only 0.016 Australian archway can be used. And this is the B is the second stage safety lock pin, and it reduces the second stage safety lock pin leaves the space of approximately 0.020, so that 0.020 inch Australian archway can be used during the second stage of treatment. And this is the hook lock pin, and this is used. And this hook lock pin is used when the major distal operating of the tooth is not required. And the hi-hat hi-hat this is the hi-hat lock pin, and this is basically used when the use of the elastics is required, and this is basically used in case of the canine bracket, because the elastic is generally applied in the canine brackets. So this is the one stage lock pin, and when the one stage lock pin is 1 point lock pin is 1 point lock pin is used, the space left is only 0.016, so the 0.016 inch Australian archway can be used. And when the second stage lock pin is used, the space available for the vertical slot is 0.020, so that the 0.020 Australian archway can be used. And this is the hi-hat hook lock pin, and the hook lock pin is generally used when the operating of the tooth is not required. So the another component of the Begg technique is the buccal tube. So it had the round molar tubes. So this is the round molar buccal tubes, which has the diameter of 0.036 inch internal diameter, and it has the length of 0.25 inch length. And it has also the hook, which is used for the ligation of the elastic, to facilitate the engagement of elastic. And the molar buccal tubes can also be flat oval, and this flat oval molar buccal tubes is generally used when the second molar is banded, and in case of the mandibular arch, when the second premolar is absent, it can also be used in the first molar of the mandibular arch. And in case of the flat oval molar tube, the end of the archway, it is bent again, and it is brought again into the major side of the molar tube, and at the major end of the molar tube, it is ligated. So for the molar tube placement, when viewed from the occlusal aspect, it is parallel to the line bisecting major distal dimension. So this is parallel to this line, and when viewed from the buccal side, it is parallel to the buccal cusp. So the another component is the auxiliary attachments, that is the lingual tubes, and this auxiliary lingual tubes should be generally attached it should be directly attached opposite to the bracket, and it should be at the same level of the archway. The another component is the elastic hook with the ball end, and it is normally attached either buccal or lingual of the molar tubes, and it is used for the placement of the elastics. So the elastic hook, the ball end, can be positioned in the lingual aspect. This is from the in the lingual aspect, and this is viewed from the buccal major aspect, and this is from the occlusal aspect and the buccal aspect. And the elastic hooks should be placed in such a way that it is as far gingivally as possible, and it should be such that it is at the pull of the elastic is from the center of the crown as possible. So this is the another component, that is the bypass clamp, and it is generally applied in the premolar brackets, because during the stage 1 and stage 2, when the pinning of the archway is done in the premolar bracket, it may cause the free hindrance in the free tipping. So in stage 1 and stage 2, the bypass clamp is used in the premolar bracket, so that it does not allow the hindrance of the free tipping of the premolar. So this is the ligature wire, and it has a dimension of 0.0072 to 0.009 inch stainless steel soft wires, and the ligature wire can be used for the tying of the arch wire to the bracket, and it can also be used for the tying of the severely rotated tooth, or when the tooth is placed far away from the idle position. So another component is the elastics, and the elastics are made from the synthetic latex and of the uniform sizes, and these elastics apply the uniform force of approximately 60 to 70 grams. This is the another component, that is the separating spring, and the separating spring. So this is the separating spring, and this is in B. You can see the separating spring that is placed in the interproximal area, and it is applied for the separation between the teeth. In case of POC, we can see that the teeth have gained the separation, and we can see that this separating spring is in the relaxed condition, and it remains in the relaxed position so that it can hold the space that it had already created. The another component is the operating spring, and operating spring has the different component. That is, this is the retentive arm, which is applied into the which is inserted into the pinhole of the Begg bracket. This is the helix, and this helix is generally 3 complete turns of the auxiliary wire, and it has also the retentive arm with a hook at the end. And we should remember that this hook should be positioned to the in the direction in which the direction of the tooth movement is required. So let's go to the Begg's different stages of the Begg's technique. So it can be divided into the 3 stages, that is stage 1, stage 2, and stage 3. In case of first stage, it generally requires the duration of approximately 4 to 8 months, and the objectives of the first stage of treatment is that the major distal correction is achieved, the correction of the rotation of the posterior teeth, the bite opening is achieved, the alignment of the anchor teeth, or the closing of the anterior spaces is done, and also the buccal correction is achieved in the stage 1. So how can these objectives be achieved? So in this case, there is rotated canine and premolar. So the Begg bracket is positioned more medially, and in case of premolar, it is more distally, so that overcorrection of this tooth can be achieved. So also the vertical loops can be incorporated into the as well, so that we can align and unravel the crowded and rotated anterior teeth. This vertical loop is generally 6 to 8 mm in height, and approximately the width is approximately 1 mm. And when this vertical loop is placed in the midline, because of the frenum, it might have hindrance. So in case when the midline vertical loop is placed, it is slightly angulated in order to keep away from the buccal frenum that is placed in the maxilla. And also the loop can be contractive loop. For example, in this case, there is a space between the anterior central incisors. So the contracting loops is placed between this central incisor, so that it can produce the major tipping of this central incisor in order to close the space. And because and also when there is not enough space between the lateral incisor, so the expansion loops are placed in between the lateral incisors in order to gain the space. Also, the elastics can be used in order to close the space which is present anteriorly. And also we can tie the elastic. So this is the loop that is present medial to the canine, and the elastic can be applied from the hook of the canine to this loops, and this can be used to close the space anteriorly which is present. And also we can give the offset, that is labial and the lingual offset. And this offset is generally also called as the binet offsets, and these offsets generally hold the teeth in the overcorrected state. And these offsets are generally placed in the between the central and the lateral incisors, so that we can hold the teeth in their overcorrected position. Also, the anchorage band is very important in case of stage 1. This anchorage band is generally the tip back band, and generally it is given to open the bite and also to preserve the anchorage. So the most accepted rule for the anchorage band to be given is to have the anterior portion of the arch wall resting passively in the mucogingival sulcus. But the Begg and Kissing in 1977 stated that the 30-degree bend is beneficial when given in the 0.016 inch arch wall. And Sims in 1977, that is in the same year, he suggested the use of the 45-degree anchorage bend. So this is the anchorage bend. The basic rule is that we should keep the anchorage bend such that the anterior portion is in the mucogingival junction. And in order to take how much the anchorage bend is given, we should hold the anterior portion of the arch wall and see the posterior portion, how much bend is given. Mondi in 69 has described the factors which affect the degree of the anchorage bend. So it depends upon the diameter of the wire, the distance of the anchorage bends to the canine. It depends upon the count of the buccal tubes, the tilt of the molars, the curve of the occlusal plane, the amount of the toe in or toe out. Also depends upon the length and the diameter of the buccal tubes, and also it depends upon the axial inclination of the anterior tooth. So when there is a blocked out tooth, this is also corrected in case of stage 1. So how it is corrected? The elastic bracket wire is generally tied from the bracket of the blocked out tooth, and it is ligated in the arch wire, and this will help us to correct the blocked out anterior tooth. And when there is severe discrepancy in the vertical direction, the initial engagement of the arch wire in all the tooth is generally not necessary. And when when the discrepancy is not significant, then only we can apply the arch wire in all the tooth. So, for example, in this figure, there is the discrepancy between the canine and the lateral incisor is significant. So the lateral incisor has not been ligated initially. Also, the elastic thread can be applied so that we can derotate the posterior tooth. And we can give the various intermaxillary hook so that we can apply the intermaxillary elastics in order to correct the molar occlusion. So the different type of the first intermaxillary hook is the boot type of hook, and it is called the boot type because the shape is similar to the shape of the boot. So it is called the boot type of the intermaxillary hook, and it is placed measure to the cuspid bracket. So in this figure we can see how the boot lobe is fabricated. Another type of the intermaxillary hook is the loop type of the intermaxillary hook, and it is also placed measure to the canine bracket. And also this is the arch contouring plier, and this arch contouring plier generally has to give the canine offset distal to the intermaxillary hook. And if the canine offset is not given, it will result in the narrowing of the cuspid. For example, in this figure B, there is not proper arch wire, and this will result in the narrowing of the cuspid. During stage 1, also the different types of elastics is used. The class 2 elastics with 2 to 2.5 ounces are used at the beginning of the treatment, and it is applied in the intermaxillary hook that is placed measure to the canine bracket, and the molar hook that is placed in the lower molar. So, and the force is generally measured through the Dontrix scales. Similarly, in case of the class 3 occlusion, also the class 3 elastics is used from the upper molar to the lower canine bracket. And in case of stage 1, also canine class 1 brackets can be used when it is required to maintain or restore the occlusal contact between the anchor molar teeth. So let's go to stage 2, and this stage 2 usually requires 2 to 4 months of treatment, and the objective of stage 2 is that it requires the maintenance of all the anterior and posterior tooth, which is correction that is achieved in stage 1, and it also Also achieves the completion of the extraction space closure by continued retraction of the anterior tooth. Also it achieves the correction of the premolar rotation, the completion of the correction of the midline discrepancy, and also the continued correction of the open bite. So this is the stage 2 model. That is the model is taken after the completion of the stage 1. And Begg has suggested the importance of taking the stage model because the stage model, it helps us to discipline the operator, and it helps us to not to mix the operator in stage 1 and stage 2. That is, it helps us to not to go in stage 2 before the completion of the stage 1. And it also provides an excellent means of demonstrating the progress and the desired relationship of the teeth to the patient. So how about the objectives achieved in case of stage 2? So the R-square generally is utilized is 0.020 R-square, and the ankle paint for the opening of the bite in stage 2 is generally less than that applied in the stage 1, because in case of stage 1 the ankle paint is given in the 0.016, what when in stage 2 it is given in the 0.020. And the horizontal intermaxillary elastics is applied in order to close the space. And in the selected cases also the intermaxillary class 2 elastic can be used so that we can maintain the edge to edge relationship of the anterior teeth. So during the space closure in case of stage 2, the molar generally rotates mesioparietally. So in order to reduce the movement of the molar mesioparietally, we can achieve this by two methods. One is by the applying the elastics from the buccal of the canine to the parietal surface of the first molar, or we can achieve the prevent the rotation of the molar by applying force from the lingual aspect of the canine to the lingual aspect of the first molar. This will generally prevent the rotation of the canine as well as the molar. Also, we can apply the diagonal elastic for the correction of the midline if there is a midline discrepancy between the arches. And also we can apply the individual we can do the individual movement of the tooth or the small group of tooth once the distal tipping of the canine is achieved. And in case of the moderate anchorage, when the loss of the when we desire to bond the anchorage, then the operating spring is generally placed in the canine of the canine bracket, and this will help to bond the anchorage. That is, it will help to move the posterior tooth anteriorly. And also the lower breaking auxiliary is placed on the lower anterior teeth, and this will help to prevent the lingual tipping of the upper and lower anterior teeth. So going to stage 3, this generally requires 6 to 9 months, and the objective is to correct all the corrections that is achieved during stage 1 and stage 2, and the main objective of the stage 3 is to achieve the desired axial inclination of all the teeth. So this is the stage model taken after stage 2 when the final space closure is done. So in order to achieve the axial inclination, the different types of the torquing auxiliaries are used. So before that, the proper arch form of the stage 3 is created. That is, the offset is given distal to the in the molar area, so that the engagement in the premolar bracket can be done. So this is the operating spring. This is the retentive arm. This is the helix, and this is the active arm. And this active arm is placed in the direction where in which direction the operating of the root is done. So when the major operating of the root is required, so when the retentive arm is inserted into the pinhole of the bracket, and this hook is inserted into this archway at this side, so that we can achieve the operating of the root in this direction. So there are different modifications of the operating spring. So for example, in this case, the operating of the central and lateral incisor is achieved simultaneously. So there is another auxiliary, that is the 4 talking auxiliary, and it is made from 0.014 inch to all 0.016 inch as well. So it has the 4 vertical loops, and it is used for the palatal talking of the 4 anterior tooth. So this talking auxiliary can be modified. So in this figure, the 4 talking auxiliary bending, as well bending is done. And the talking auxiliary can be modified in such a way that when only the central incisor talking palatal talking is required, then these vertical loops can be placed only in the central incisor, and when the central incisor palatal talking root is required, and when the labial talking of the lateral incisor required, so this is the figure where the palatal talking of the central incisor is achieved, and in case of the lateral incisor, in this case, the labial talking of the lateral incisor is achieved in this figure. This is again another talking auxiliary, where the simultaneous central and the lateral incisor of the left side, left and right side is achieved. This is another auxiliary modified so that the and in this modified auxiliary, this only the labial talking of the lateral incisor is required, and the talking of the central incisor is not required. So this modified auxiliary can be used for such purpose. So this is the auxiliary. So this type of the modified auxiliary can be utilized for the labial talking of the lateral incisors. So this is another talking auxiliary, and it is called the mandibular reverse talking auxiliary, and it is used to talk the mandibular incisors root labially. So it is since it is talks the incisors root incisor labially, it is called the reverse talking auxiliary. So this is another talking auxiliary, and it is called the pre-wound or the rat trap talking auxiliary. Because of this, because of the complexity and precise nature of the wire bending that is required in case of this pre-wound rat trap, also called the rat trap talking auxiliary, it is generally not utilized in the Begg's technique. But it is generally fabricated with 0.014 and 0.0 or 0.016 inch round as well, and it is generally placed in the base as well of 0.020. So when the lingo talking of the central incisor is required, and the labial talking of the lateral incisor is required, so this talking auxiliary is modified accordingly. So this is the talking auxiliary that is placed after the space closure in stage 2, and it is placed in the direction. So in case of this premolar, the medial uprighting of the root is desired. So this hook is placed medially, whereas in case of the canine, the distal root uprighting is required. So it is placed in the distal direction. And also the arch wire in the distal to the molar tube, it should be bent so that the space closure during the uprighting is prevented. So going to the disadvantages of the Begg's technique. So in case of the Begg technique, it is unable to achieve the precise control of the precise control is unable to achieve in case for the final finishing in case of the Begg technique, and also the posterior root torque is very difficult, and also the rotational control is poor with the use of the because in case of stage 1 and 2, the undersized wire is used, so the rotational control is difficult in case of stage 1 and stage 2, and also the patient control is required for the use of the elastics. And since the right arch wire is used, the distortion of the arch wire may take place during the mastication, and the auxiliary attachment that is placed during the stage 3, this may hamper the maintenance of the oral hygiene. So in order So in order to remove this benefit, remove these disadvantages, the biggest type of the Begg technique has been different types of the Begg technique is formulated. So the modification of the Begg technique is one is the refined Begg and another is the modified Begg. So in case of the refined Begg, this refined Begg uses the same Begg bracket, but the same Begg bracket, that is the gingivally oriented vertical shot. But in case of the refined Begg, it uses the improved biomechanics. And in case of the modified Begg, the core wire philosophy remains the same, but in case of the modified Begg, the bracket designs have changed. For example, the combination bracket. So we will talk about the different modification of the Begg bracket given by the different authors. In case of the modified Begg, generally the combination bracket is used. For example, in Thomson in 1981, he developed the combination bracket, which uses the advantages of the both the Begg and the straight wire. So this bracket utilizes the principle of Begg for tipping the tooth, and for the correction of for the bodily movement, it utilizes the principle of the edgewise bracket. So in case of the modified Begg, it has the bracket. The bracket is designed in such a way that it has the gingival third of the bracket has big bracket, whereas the occlusal two third it has the edgewise bracket. And it has this bracket has also the in-out positioning as well as the pre-angulated and the pre-torqued. So so this combination bracket given by Thomson has this the gingival third. The gingival third has the big bracket, big slot, that is the vertical slot, and the occlusal two third has the edgewise bracket. So so it is the four-stage bracket. During stage 1, stage 2, and stage 3, the big slot is utilized in order to achieve the advantages of the Begg's appliance. And once the space is closed, the archway is inserted into the Begg slot, so that the root operating can be achieved better in the fourth stage. So during stage 1, stage 2, and stage 3, the pure Begg mechanics is utilized by incorporating the archway in the Begg slot. And after the stage 3 is done, so in the Begg mechanics, generally the second molars are not incorporated. So after the stage 3 is completed, the second molars are labeled, are also incorporated. It is aligned and labeled, and the finishing mechanics are applied through the use of the edgewise slot. So for example, in this case, the edgewise slot is utilized until the stage 3 is reached, and once the stage 3 is reached, the slot, the archway is inserted into the. So this is the Begg slot. So stage up to stage 3, the the archway is inserted into the Begg bracket, Begg slot, that is the vertical slot, and after stage 3 is completed, this archway is inserted into the edgewise slot, so that the proper operating of the spring can be achieved. So this is another example. Since the second molars are not incorporated in the Begg mechanics, so before going to stage 4, the second molars are also incorporated. And once the second molars are also incorporated, the archway is incorporated into the edgewise slot. In this case, the archway is inserted into the Begg bracket, into the Begg slot, whereas in case of stage 3, the archway is inserted into the edgewise slot, so that the proper control of the tooth can be achieved. So there is another combination bracket that was given by Richard A. Hokeberg in 1985, and this is called the Bediet bracket, and the full form is Begg edgewise diagnosis determined, total individualized orthodontic treatment. And it had both this combination bracket has both the slot, and it has the edgewise slot of 22 by 28, and it has the vertical slot of 20 by 20 inch. So this is the bedded bracket. In this bracket, it has the edgewise slot of 20 by 22 by 28, and it has, and we go to this edgewise slot. There is also the vertical slot of dimension 20 by 20 inch, and this bracket can be can be simultaneously utilized whether to achieve the benefits of both the edgewise as well as the being mechanics. So it has the 20 by 28 inch facial lingo horizontal archway slots, and on the lingo side of this edgewise bracket, it has the dimension of 20 by 22, 20 by 20 inch vertical slot. And this bracket can also be sometimes rotated horizontally. Since we know that it has the vertical slot, so this bracket can be rotated by 90 degree, and this can be placed in the partially erupted as well as in the unerupted tooth, and this bracket sometimes can act as a miniature buccal tube. So there is another modified Begg bracket that was given by Sharma and Sen Gupta in 2009. And what they did was they used the edgewise bracket of 22 slot in the. So this is the edgewise bracket which they generally use in the incisor bracket, that is central and lateral incisor. Whereas they use the bondable Begg bracket. So this is the bondable Begg bracket that they use in the canine and the premolar bracket. Now, the another modification of Begg appliance, that is the refined Begg appliance. This was given by Akira Kameda of Japan, and the modification of this Begg technique was done in order to suit their the population of Japan. And this Kameda made the refinements on of the original Begg. That is, they use the same Begg appliance but with the improved biomechanics. They made the refinements in the anchorage bends. Also modified the mechanics for the wide opening. Also, they modified the uprighting spring and also the torquing auxiliary. And also they modified the bracket in such a way that they had the torque that was built in the Begg bracket. So generally, this Kameda modified the bracket in order to suit the population of Japan. So in case of the people of Japan, they had the archway of the arch shape. In case of the Japanese population, had the more the buccal window width of the canine was more than the other Caucasian population. So they modified the archway in such a way that they had more canine cuspid, canine canine curvature in the both the upper and lower arch. So so this is the modification in the archway that was done by Akira in so that they can suit the population of Japan. So there was more canine offset that was given for the canine offset that was required in the population of Japan. So these are my references. Thank you.